And it's a real pleasure to have Dr. James Andrews to join us from Sunderland Royal Hospital and to talk to us about lung ultrasound and his experiences in COVID. Thank you very much.
Thank you so much for the invite. I think with Dr. Ibrahim's help and support, we've managed to get through the technical difficulties. Right. Thank you for a really interesting talk before. That was a really stimulating discussion as well. So I'm a renal physician and acute medicine physician based in Sunderland Royal, and I've been asked to talk to you for half an hour, 45 minutes on point of care ultrasound and its use within COVID-19. Sorry. Okay, can we do the next slide, please?
Switch on your video. Do you have that available or not?
Yep.
That's it. Great. Thank you. Thank you.
Hi. So can we do the next slide, please? So in terms of my conflicts, I've got no particular conflicts of interest. All right. And in terms of what we're going to try and cover, so we'll be talking about point of care ultrasound and the abbreviation POCUS, basic ultrasonography. We'll be talking a little bit about ultrasound physics, the evidence base behind the use of point of care ultrasound, lung ultrasound in specifics, and then moving on to lung ultrasound in COVID-19, examples of how we're using this in the United Kingdom and some new technologies that are coming along to hopefully be of benefit. And then if at the end, we'll take any questions. So we're not going to be covering in particular M-mode ultrasonography, Doppler ultrasound and pulse wave Doppler. The physics that I'm doing is already quite detailed. So what is point of care ultrasound? POCUS or point of care ultrasound is exactly what it sounds like. So next slide, please. The traditional model of history taking examination is kind of described on the screen as you see it. And so the physician will ask and will kind of interpret the history from the patient. There'll be an examination, and then normally we'll ask for some tests. And so that will mean that you'll then need to send the patient away for some investigations. Those investigations will happen. They'll then be in some sense interpreted by someone else. And then that information filters back to the clinician who's looking after the patient. And in the intervening time, this can be 2 days, 3 days, depending on where you're working. All right. Next slide, please. Or just one slide forward. So the advantage of point of care ultrasound is that the person who's there doing the history and examination, who's the primary physician, can actually assess and do some focused ultrasonography to actually help you in aiding your clinical impression at the time that you're seeing and acquiring the images from the patient. And so the advantage is that it takes out a step from the process. I would stress early in the talk that we're not looking to become ultrasonographers, we're not looking to become radiologists. We're looking to do a very, very narrow investigation, looking to ask and answer a specific question at a specific point in time. And part of that, the importance of that is that asking that question at that point in time means that you can affect management and then reassess. And so point of care is something that I frequently do on a stepwise basis and reassess the patients as you go. So what does it look like? Point of care ultrasound looks like this. This is an image of a patient who's a post-trauma patient being assessed for a pneumothorax. And there's an ED physician on the left-hand side who's doing a lung ultrasound, having a look to see if this patient needs intervention before they're stabilized and moved to another department. And so it is real time. It's a physician who's doing the images, and this is just so you have a bit of an impression in case you've never come across point of care ultrasound being used before. So what are the advantages of point of care ultrasound? So as I've mentioned before, it's safe. There's no ionizing radiation in use whatsoever. Okay, it's very hard to hurt someone with an ultrasound wave. The equipment itself, and this is something that I'll come to later on, is getting increasingly easy to use. And so instead of it being a large room full of equipment to generate the ultrasound waves, actually increasing this is done with a simple tool that you can fit in your back pocket. The speed is a definite advantage. And in the era of COVID, we're noticing that the findings are actually comparable to the gold standard imaging modality for coronavirus, which is CT-based imaging. We're also noticing that this then means that you can reserve the CT scan for people who actually need to have those investigations and a definitive management. The reason why this is important is that if you've got a patient who's a suspected COVID patient going in to have a CT scan, then that's a 45-minute time for that room to be turned around with cleaning before and cleaning after on transfer to radiology. So it's very easy to limit the amount of scans that your department are doing. And this is indeed one of the reasons why bedside ultrasound was initially used in coronavirus. But we'll come on to that in the discussion later. So to talk about ultrasound, we need to know a little bit about physics. And as a general physician, this is something that I didn't know anything about before I developed an interest in point-of-care ultrasound. And so we'll quickly whip through some basics, such as what is ultrasound, how is it generated, and some core concepts which will help us interpret the images. Okay, so ultrasound's very simply described as just that. So there's something that we as human beings somewhat arrogantly refer to as being the range of hearing, and any sound that is above that in terms of its frequency is referred to as being ultrasound. So we can hear up to 20 kilohertz. Okay, bats can hear somewhere between 20 and 200 kilohertz, and then we have diagnostic ultrasound. Okay, so medical ultrasound is diagnostic ultrasound is somewhere between 2 and 20 megahertz. Okay, and this is the range of hearing that we tend to this is the range of ultrasound that we use, and the range itself will come on to how that affects what we're doing with how you use scanning. So how is an ultrasound wave generated? So this is through something you might remember as being called the piezoelectric effect. Okay, and this is a property of the substance to allow it to convert kinetic energy to electrical energy. Okay, and so if we just click one forward, sorry, I think it's on a perfect, yep. And this is how ultrasound transducers receive sound waves and turn them into images. Okay, and so by applying the inverse of this, okay, this means that we can apply electrical energy, and this means that it can form a very, very minute kind of change in the structure of the crystal, or the property that in this case we're using a crystal, and this means that it will then generate sound waves. Okay, when an alternating electrical field is applied, this crystal then rings like a bell, so it produces one resonant frequency. The determination of that is mainly based on its thickness. Okay. So you apply electrical field, this generates a change in size, this then generates an ultrasound wave. And then you can ask the machine itself to interpret the images coming back if they're coming along at the same frequency, and that generates an electrical current which can then be interpreted by the ultrasound machine itself. And so what does this look like in real life? So we have, as a kidney doctor, I'm obviously going to choose an image of a kidney, but we have somebody who's being scanned here. The probe sends out electrical input, sends out ultrasound waves. These ultrasound waves then bounce off various different tissue densities and then come back. Okay, but how does that then generate the grayscale image that we're then seeing here on the right-hand side? So this is what we're going to talk about. We're going to talk about that by exploring some of the core concepts of ultrasound. Okay, so to talk about ultrasound is to talk about waves. Okay, we talk about sound waves, but a lot of the principles that we have from general waves, okay, all hold true. Okay, so the concepts we're going to cover are frequency. Sorry, next slide, please. Okay, frequency, wavelength, acoustic impedance, reflection, refraction, and attenuation. Okay, and we'll use lots of pictures to go through this as we go along, and echogenicity. So frequency and wavelength. The frequency is the number of sound waves that happen in a second. Okay, and then the wavelength is the length or distance of a single cycle of a wave. Okay, and so that helps you when you're coming to think about which ultrasound probe you want to use for any particular situation. Because for imaging superficial structures, you want to use something which is a short wavelength and a high frequency, because that means it gives you lots of detail of superficial structures. Okay, so that would be a linear probe, for example. Whereas when you want to image something that's deeper, okay, you want a long wavelength and a low frequency. Okay, so this would be something like a curvilinear probe that we use here. So acoustic impedance. This is the resistance to ultrasound propagation as the ultrasound wave passes through a tissue. Okay, so this is a property of a tissue itself. It's a physical property of the medium. Denominated as Z, is dependent on the density of the tissue. Okay, and the impedance then is the density multiplied by the propagation speed of sound wave. Okay, so you might have come across these reference tables if you've ever done any studying of ultrasound kind of in the past, if you've ever come across this as something that you taught. So next slide, please. And there are reference tables which give you the speed of sound in tissue, okay, and the acoustic and impedance value of those tissues, okay. And then also on the far right, the attenuation. So we're going to go through this in a little bit more detail. So the reflection of ultrasound waves, sorry, so if we just go to the next slide, please. At the interface between the tissues with different impedance values, then the ultrasound waves reflect, and how much they reflect, or the proportion of ultrasound waves reflected, is relative to the difference in impedance of the two tissue types, okay. And as a reference here, we have the speed of ultrasound in soft tissue is almost constant at 1.5 kilometers per second. So we'll talk about that in terms of some images in a second, but then coming on to another core principle, we have refraction. So you'll remember this image from basic physics and being taught at high school, I'm sure. Waves and speed of light waves in this particular instance travel faster in different mediums. And so the light that's coming from the glass is curved as it goes through the water, and that means that it distorts the image that we receive. And so if we just click on forwards, this is true in ultrasound as well. So you can see that there's an edge artifact here. There's a shadow from the internal carotid artery that's passed as the sound waves travel through the water that's inside, or the blood that's inside the carotid artery. And that's a different speed relative to the tissues that are around them. And that means that it creates an artifact at the edge posterior to that cast by the ultrasound itself. Okay, next slide, please. So attenuation. Attenuation is how rapidly the medium reduces the intensity of the ultrasound wave passing through it. Okay, so there are some materials, okay, such as ribs. If we just click forward one, please. Okay, so the ribs, which will be highlighted in a second. Perfect, lovely. So the ribs, this is a lung ultrasound, okay, with a linear probe, okay. The ribs have got a very, very high value of attenuation, so they reduce the intensity of the ultrasound wave to the point where it doesn't actually pass through that area, and so it casts a posterior shadow, okay, whereas the lung itself, okay, we'll talk about the artifact that's being displayed in a second, but the lung itself, the pleural line is picked up, and the superficial tissues, as you can see, are denoted quite well. So again, coming back to that core value in the core table, this is the attenuation value that we're looking at there. The attenuation, as you can see in air and bone, are the ones that I'm going to draw your attention to there. You can see that actually the attenuation is very, very high. That means that ultrasound waves do not propagate through these mediums at all. And you can use that as a way of interpreting the images when you're looking at them, because if you look at something and there's a posterior shadow, then you can say that there's something there that's stopping the impedance or stopping the ultrasound wave from being transmitted further. Okay. So, echogenicity. So, echogenicity is a common term in ultrasonography, and this is just to get you used to this term. It's how echogenic something is relative to normal body tissue. Okay, hypoechoic is less echoic. Okay, isoechoic is about the same echogenicity as normal tissue, and hyperechoic is more echogenic. And we've got some examples coming up. So, hypoechoic. Next slide, please. A good example would be urine that's in the bladder. So this is a transverse image of someone's bladder, okay, with fluid that you can see in black. The hypoechoic substance that you're seeing there is just that free water, and because it's not actually reflecting in ultrasound waves, it's black to the ultrasound machine. So all of those waves get transmitted through, and you get good detail of the tissues that are distal to it. Okay. Next slide, please. So now, when you have something heterogeneous, such as muscle tissue, you get a huge amount of grayscale detail in the image. And so this is a really echogenic substance. So we're looking at actually the flexor muscles of my hand. And you can see that there's actually quite a huge amount of detail that we're seeing in each of the muscle fibers being picked up there in really, really beautiful, nice detail. Okay. But that's because they're all subtly different to the surrounding densities there. Each of the muscle fibers is being highlighted on its own because it's not the same density as the one that's adjacent to it. Okay, so then we come to something which is very, very hypoechoic. So this is where we have a bowel gas. So this is a curvilinear image of someone's abdomen. Okay, to the left of the image, as you look at the image, okay, at the side of the dot, okay, is a liver, and then underneath that, the bright white line that we're seeing there is actually bowel gas. Okay, so there's a very, very high difference in the acoustic impedance at the surface of where the air is in the bowel, and that means that none of the ultrasound waves propagate through the air, okay, and they're all reflected back towards the ultrasound probe, which sees this as a bright white line, okay. So next, please. Right, phew, we made it. Okay, so that's the ultrasound physics section over. Now we're going to talk about lung ultrasound and how it's relevant potentially to coronavirus. So lung ultrasound, as we've said, is a subsective point-of-care ultrasound, and this is a rapid bedside point-of-care test that can be used to aid in the workup of dyspnea, so undifferentiated breathlessness. In the United Kingdom, we've actually got a joint position statement released by the Royal College of Radiology and the Society of Acute Medicine, which has actually recognised the value of point-of-care ultrasound. Okay, so this is something where the Royal College of Radiology, and I'll stress again, I'm not a radiologist, I'm just a keen amateur, but the Royal College of Radiology are recognising that in the right situation, point-of-care ultrasound has a distinct value. Okay, so we're going to talk about the evidence base behind lung ultrasound in a little bit more detail. So this is a 2010 meta-analysis from Wang et al. Okay, and this was looking at a unselected take presenting to emergency departments, okay, with a suspected diagnosis of heart failure. Okay, and so they looked at their take over a period of 12 months, and they then looked at the admission presentation, either the history or examination findings, okay, and then followed these patients through to discharge and looked at the pretest probability, the sensitivity, specificity, and positive likelihood ratio and negative likelihood ratio of all the typical kind of symptoms and physical examination findings that you'd expect to see in people with heart failure. And so if we just click next, thanks. And so what you can see is that as a test, okay, history is not very sensitive for assessment of people with acute heart failure or as part of an assessment of breathlessness. And also physical examination findings really don't either lack in either sensitivity or specificity when it comes to assessing people for whether or not they actually have acute heart failure. So likelihood ratio, just as a very quick reminder for those of you doing your statistics, so that's the how good your test is. So if you have someone who has got a history of cardiac disease who comes to you and you're sat in an emergency room or you're sat in a cath lab and you get a history of someone who's got acute central chest pain radiating to the arm and jaw, they look grey and sweaty. You know, if you go and see the patient, you might think that person's got maybe 80% chance of having an MI. If a nurse then hands you an ECG and that ECG has got ST elevation in the anterior leads, then that then changes the odds of that person from having an acute MI from being 80% to being 99%, say, because you'll recognise there are other causes in the 1% of people who could have those ECG changes. So the change from 80% to 99% is your likelihood ratio. Okay, so positive is good, negative being bad. So in terms of likelihood ratio, we can see that the assessment finding that best correlated on examination with someone who actually had acute heart failure with a positive likelihood ratio of 11 was a third heart sound, but it's not a sensitive finding in terms of its positive diagnostic value of 0.13. And so how does this compare? Sorry, now next slide, thank you. So how does this compare with the use of lung ultrasound? So in two centres in Italy, they looked at 518 patients who presented with breathlessness and suspected heart failure, and they did a typical diagnostic workup. And so that consisted of most people of history examination and then a chest x-ray and a BNP. And that was found to have around about 85% sensitivity, 89% specificity with a time to diagnosis of around about 104 minutes. That compared to lung ultrasound, so an 8-line assessment of these things called B lines, and we'll come to that in a minute, which was 94% sensitive, 96% specific, and had an average time to diagnosis of 5 minutes. And I think that 4 of those minutes were probably finding the ultrasound machine. And so lung ultrasound has got a good basis for the assessment of heart failure and workup in the emergency department. But the question is, can we then generalize this out? Is there further evidence? Okay, so next slide, please. So this is not just one study, and so this particular meta-analysis has looked at 7 prospective case studies of over 1,000 patients, evaluating the sensitivity and specificity of B lines in diagnosing acute pulmonary edema. Okay, so this again in the emergency department where most of the literature has been collected, as our colleagues in ED have been more rapid at picking up the use of ultrasound than we have in acute medicine. Okay, so again, really good sensitivity, really good specificity, good positive likelihood ratio, and a good negative likelihood ratio. So can we use this for anything else? Can we use lung ultrasound for anything else? Next, please. So our respiratory colleagues tell us that they've been using pleural ultrasound, pleural ultrasound for years. And again, pleural effusions and the work of pleural effusions have been a part of a standard respiratory assessment now for a number of years. And this is again another meta-analysis of over 1,500 patients. And ultrasound compared to CT was again 94% sensitivity, 98% specificity, with a very strong positive likelihood ratio and a very, very good negative likelihood ratio. Okay, so we can use it for assessment of heart failure. We can use it for assessment of pleural effusions. And then next, please. And this takes us back to our initial slide of the image of one of our ED colleagues imaging and looking for pneumothorax. So actually, lung ultrasound is more sensitive than chest X-ray in the right hands at assessing for pneumothorax. Obviously, there are a number of disadvantages, and I'm going to suggest that you move to only using lung ultrasound to assess these patients. But as an initial assessment, when again a prospective studies of over 1,000 patients, we're able to pick up with a high degree of sensitivity and a high degree of specificity evidence of traumatic or iatrogenic pneumothorax. Okay, so we know that we've got, sorry, next slide please. So we know that we've got a good evidence base for the assessment of dyspnea, okay, and the workup of dyspnea for a number of different respiratory conditions, and also pulmonary overload in the context of acute decompensated heart failure. So how can we use lung ultrasound in coronavirus? Now, as I was saying when we had our initial technical difficulties, if you're looking to design a condition, a disease where lung ultrasound would have a use, then you would design something like coronavirus. It appears very similar to other types of viral pneumonitis. And so the first point to make is that when you're imaging someone, you could be seeing any kind of viral pneumonitis, okay? But in the right clinical setting, and if you have an outbreak, then coronavirus can be imaged because it affects the terminal alveoli close to the pleural interface. Now, a number of people initially in China picked up on these changes on lung ultrasound, predominantly because they found that their ability to CT everyone, okay, was severely impaired because of the need to clean the rooms before and after each patient was transferred for imaging. And so Huang and Peng then were able to pick up that lung ultrasound changes were present at the same time as CT appearances, and that CT appearances could actually precede typical respiratory symptoms. Okay. Peng then went on and did some further imaging studies, again in China, looking at correlation between CT and lung ultrasound appearances, and found that actually the CT could pick up lobar disease, as could lung ultrasound. And so it's a very, very specific way of picking up very focal disease. It's subsequently been proven in a further analysis from Tierney et al. In the States to be more sensitive and specific than chest X-ray. And the way in which they did this study was that they had people on an intensive care unit who within 24 hours of being intubated had a lung ultrasound, had a chest X-ray, and had a CT. And then they went back through all these patients and looked at how well the CT, which they referenced as gold standard, correlated with both the lung ultrasound findings and the chest X-ray findings. And Guan et al. Has kind of taken that work further and has looked and shown that chest X-ray could potentially miss up to 40% of coronavirus cases. Next slide, please. So what do we see when we image people, and what's the normal kind of appearance of lung ultrasound? So as we showed you earlier, the normal appearances of lungs are these artifacts called A-lines, and this is a resonance error that you get where the lung ultrasound probe thinks that it's seeing the same image multiple times going down. And so on either side, you have the rib shadows, and they cast their posterior shadow. You can't see anything that's black, okay? And then you get these A-line appearances, which we'll show in a couple of images. So in the abnormal area that you see with the interstitium on the right-hand side of the screen, these patchy B lines, this is the coronavirus. This is actually coronavirus that we're seeing in the terminal alveoli. That then sets up a resonance image that then creates these posterior B lines. And so it's almost like someone standing on the pleural line and shining a torch back into the chest. And so you can see these lines spreading up and down beautifully. And then because it's a pleural disease, you actually get an irregular pleural line. The pleura itself can then get infected, and there can be further consolidation, and you can see that as well. And there are a number of studies that are looking into assessing the severity of lung findings with coronavirus. and correlating that with patient progression, but there's none that I'm aware of so far that have been actually positive. Okay. So, next slide, please. So this is what we see. So these are images that I've, these are some images that I've found online actually. On the left, if we just click forward once more, they should become labeled. So on the left, we have a normal interface of lung pleura, okay, and with the resonant A lines as we described. And then, sorry, could we just go forward one more, please? Sorry, it should label the images. Oh, no, sorry, yeah. And then just, perfect, yeah, here we go. And then we can see here, on the right-hand side, as you look at it, that we have an irregular pleura, okay, and you have these posterior B lines. So it's, as I said, like a torch is being kind of shone from the pleura, which is irregular itself, okay, and you get these posterior B lines. Now, in coronavirus, one of the typical findings is you can actually get these skip lesions, and so the B lines can merge together. And so instead of being one distinct area, it can be a few different areas appearing together that are then cast in this posterior line. And these B lines, as you can see, obliterate the normal lung architecture. So on the left-hand side, you can see the A lines perfectly displayed. You can see that they're intermittently appearing and disappearing as the abnormal area of lung slides in and slides out of the ultrasound view. Okay. So now this is just, again, sorry, a further kind of pictographic representing the change in coronavirus as we see it on lung aeration. As we see it kind of depicted on ultrasound. This graphical representation I find is quite useful, and it correlates on the bottom, as you can see, the CT findings versus lung ultrasound findings in the various different stages of the disease. Okay. So, how's this been used in the United Kingdom? A centre in Lewisham had 3 consultants who had experience of performing point-of-care ultrasounds, and they noticed that they were having a number of patients who they were triaging as being low risk of having coronavirus, who were subsequently proving to become quite unwell and then passing coronavirus to other patients in hospital, and this was potentiating outbreaks. They decided to use the features of coronavirus, in that it was something that could be readily detected on ultrasound, to then triage people front of house. And so they actually went out into the ambulances, people arrived, and in the waiting rooms, they then triage people to, on the basis of their history and examination, and also the assessments that they did with the ultrasound, to then triage people either into coronavirus or non-coronavirus areas. And they found that out of the 50 patients that they studied in their pilot audit, around about 20%, so 10 patients, actually had evidence of an interstitial pneumonitis, which would be in keeping, viral pneumonitis, which would be in keeping with coronavirus. And the problem that we have here is that the limitation in the United Kingdom is that not all of those patients then have positive swab tests. There can still be clinical suspicion, but as you're all aware, there is a limitation in terms of the diagnostic ability of the labs to be able to pick up this condition. So obviously with our swab rate having a false negative of 20%, that means that we don't always catch this condition. Right, so they have then trained up all of their staff to be able to perform point-of-care ultrasounds. It's been a huge undertaking, and they're doing some really interesting and exciting work there. Okay. So this is, on the next slide, their triage pathway and their triage document. And so they have triaged on the basis of history findings. And so if you had any history findings, you were triaged to a high-risk area of people who were suspected coronavirus. And then even if you had no history features, but you had positive lung findings, you were still triaged to what they call their red zone, their coronavirus zone. Okay, and they've had great success with this. So if we go on to the next slide. So this is the actual data from Dr. Colclough, who I've spoken to about this, who set up the original work at Lewisham. They then audited their practice. They looked at 50 patients and, 40 patients, 50 patients who they triaged, And this was at the height of their outbreak. And so 40 patients out of the 50 they triaged went to their medium or high risk for COVID, and 39 were subsequently confirmed with PCR CT chest. 14 were listed as negative PCRs, but COVID was still the high risk, was still the clinical diagnosis from the admitting team. Okay. One patient was diagnosed with heart failure because there's sometimes a similar B-line picture, and 10 were subsequently diagnosed as being COVID. Okay. So that's how we're using lung ultrasound to triage in the United Kingdom. Now, how is ultrasound changing? So we're going to talk about a new technology. So this is a point-of-care ultrasound machine, and this is a Butterfly IQ that plugs into your phone and actually turns your phone into an ultrasound machine. The advantage of this is obviously you then don't even have to worry about having a cart-based system to decontaminate. You can actually have a just a simple probe cover, and then you can scan at the bedside. The images are all stored remotely if you choose to store them. We haven't got through the clinical governance to be able to do that yet. And you can actually share these images with colleagues. And so one of the things that we've been able to do in our centre is that, so next slide please, is that as these technologies evolve, you can actually get remote scanning possibilities. And so Dr. Ahmed was in hospital and was wanting to have some assistance scanning a transplant patient. This is whilst I was at home having my Sunday dinner, and I got a phone call for some assistance, and I was able, with this new kind of piece of equipment, to be able to actually remotely connect with him whilst he was scanning in real time and assist him in scanning a kidney transplant. And so the possibilities for these devices are really quite marked and really quite profound. And there's a number of these devices being used in low resource areas where you don't necessarily have access to a £30,000 ultrasound machine. It's a lot more palatable for people to pay, or people to be able to afford £1,500, or in some cases, be able to kind of talk to the company and get them on charitable means. Okay. So this is the latest Banks image, which I thought was quite remarkable, and I was a big fan of. And this just reminds us that it's a challenging time with coronavirus, but hopefully we'll be able to get through it, and hopefully the public will reaffirm who they think their heroes are in the future. So I'm happy to take any questions.
Thank you very much, Dr. Andrews, for this fantastic talk. And this is an opportunity for the panel members. Any questions or comments?
Can I jump in if you don't mind?
Yes, of course.
James, fantastic. Thank you very much. It just validates the vote of confidence that we all put in your ability to lead us into the 21st century with ultrasound. Fantastic. Well done. Can I just say, I'm presuming and hoping that you are collecting some data and you're keeping a record of what is being done and so on and so forth. And we very briefly kind of talked about the developments in ultrasound before while you were getting your talk prepared, and I had one specific experience that I wanted to mention. I think you've clarified my query as you've spoken, is that the features that we are seeing on the point of care ultrasound with the equipment you have would suggest that the changes seen are actually non-specific to the causative agent, but are more relevant to the overall clinical presentation, i.e. somebody's got pulmonary congestion or they've got extra alveolar fluid, which is either a primary reason for their symptoms or a response to the illness that they have. And I think we just need to be careful until we get proper registry-based large volume data to link this to any particular illness or particular clinical presentation, because my personal experience in our institution has been at the receiving end in the respiratory assessment unit of a steady stream of patients being filtered through from the emergency department with a single statement at the bottom end of the inpatient electronic note saying POCUS suggests consistent with COVID-19, and you're kind of thinking, yes, does this really, what does it mean, etc. So I think it's the interpretation, and we are probably all in that learning phase of how to deal with this information. I think what you have very superbly demonstrated is the value of technology and the clinical implementation of that technology. I think linking that implementation to the outcomes and to diagnoses or specific diagnoses and specific management strategies, because what I would love to see is the results of patients who are treated based on POCUS findings with specific disease modifying treatments, and then repeat POCUS to say that is what we can achieve. That would be phenomenal.
Thank you so much, Professor. That's an absolutely fantastic point, and I couldn't agree with you more. One of the values of point of care, as I see it, is the repeat assessment. And so much in the same way that if you had someone with heart failure, you would listen to their lungs on a daily basis to make the assessment of, do I think that person's still congested? But take that as part of the overall assessment. You know, what's their urine output been? What's their dry weight done today? What's their feeling like? You know, are they more or less unwell? I think that a one-off snapshot, an image in time, is useful, but it can never be fully diagnostic, okay, or rarely can be fully diagnostic. I would be keen to have a cohort of acute medicine physicians and colleagues who are all trained to be able to do this, who can then do the serial subsequent assessments, because then it means you can modify your therapy instead of having that one-off statement of, we think it's this. And also I think we need to have the analysis of the data in more detail to say, well, the changes that we see in coronavirus are very, very similar in some situations to the changes that we see in heart failure. There are definitely specific differences, but then having the ability not just to do the lung ultrasound, but to maybe do a focused echo, maybe to then look at the lung basis, maybe to look at the inferior vena cava, look for DVTs. I think it needs to be part of a comprehensive assessment, not just a one-off snapshot of, this is their lungs, this is the diagnosis. Medicine is very rarely that black and white.
Yes, absolutely. Absolutely. So, no, thank you very much. And I think, like yourself, I'm keen to see data on serial scans for patients with acute illnesses, and maybe streams of that activity specific to diagnosis. So people with basal consolidation due to infective bacterial infections versus viral pneumonitis versus heart failure versus COVID versus renal transplant patients, acute AKI.
Absolutely.
It's phenomenal to have a database that would say these are the specific or non-specific changes that you could perhaps link to disease-specific diagnoses. That'd be fantastic.
It's a really powerful tool, and I think it's got to be, I think the thing that I don't want to do is to discourage people from putting a probe on the chest, much in the same way that we're all learning when we're doing our residency and training to be able to kind of listen to chests and listen to hearts. There is a learning period that comes with lung ultrasound and that comes with any new skill. And we need to support people as they learn and as they train.
Yeah, I think just with the slight caveat of utility of resources as a consequence of what you find should be monitored and measured.
Much in the same way that you have your OSCEs when you do your medical school. Absolutely. There should be an assessment, a triggered assessment that then takes people through and says,
Once you go through that phase of having supervision and acquired a level of expertise and knowledge, then you can work as an independent practitioner, which is
absolutely
curriculum and all that sort of stuff is about. But at this stage, I would be keen to see this in the hands of people like yourself who've got experience, who've got the understanding, and more than that, have actually got the clinical sensibility of using the information that you're getting, rather than devolving it to just being the front door triage test of component positive has to be an acute coronary syndrome type syndrome. Well done. Thank you.
Thank you.
I think Dr. Saeed has a comment or a question.
Thanks, James.
I would be surprised if he didn't.
Yeah. Thanks, James. Wonderful talk. Yes, it's a great asset to the department. The point you made is these devices are not as expensive as they were before, and they're more handheld. So you can see what's going to happen. Because they become cheaper, they're more readily available, and you run ahead of the training. So a lot of people privately have bought these devices. Some institutes have bought them like we are trying to do, in a controlled manner with it, alongside curriculum-based teaching and certification. And there's some private individuals who brought the device. So I think that needs to be controlled a little bit, and that needs to be certified through your learning on your e-portfolio or through your curriculum. Having said that, I've been a very great proponent. Front of house, ED, acute medicine, always get the new toys. Always get the new things. Cardiology, always get the new things and all the toys. Us poor people back of house, where we are still with that thing called stethoscope, it goes between you guys, use it now and then. We don't get these devices. I remember people came back from Afghanistan and intraosseous needles were a big thing for really difficult access. Came to front of house, came to ED, came to other areas. People like us, as nephrologists, we deal with really difficult access. And it came to us very late, but we never used it. Similar to this, but actually this time round, I think it's the first time where back of house doctors, i.e. general medicine doctors, the ones that nobody likes doing, are influencing front of house. All the high-end specialities, cardiology, ED, acute physicians. And where I'm coming from is, don't forget the junior doctors, venipuncture, venflons, arterial blood gases. These are far more commonly done than any of the procedures that we do front of house. And we go around on our ward rounds and see people's veins emaciated with a number of phlebotomy attempts. And obviously we don't like it because we need the veins for vascular access. You need the veins for radial approaches for your cardiology, and also daily blood tests are asked for. But we're training juniors to do multiple venipunctures on very frail elderly people. We don't give them this skill of ultrasound, which really doesn't require a lot of information. So I do think we need to approach it from both sides. Front of house assessment, repeated assessment, and then back of house for simple basic procedures. It should be helpful. So we're attempting to do that in certain areas, but as the price comes down, it should be almost the norm for those simple things anyway. That's my comment.
Yeah, I'd just like to thanks very much. I'd just like to just ask Dr. Budbury to give us some of his experiences, because he's been using ultrasound, portable echoes, for screening of people in the rural areas of Sudan with mitral valve stenosis. Dr. Budbury, would you like to make a comment about, especially with the portability, these handheld echo machines and ultrasound machines? Would you like to just give us a bit of, tell us your experience very briefly?
Thank you. Actually, our experience with the handheld echocardiogram, which we use, it is not widely available in Sudan. I've got very few devices being donated to us by charity societies. And we are using that actually to scan a patient with suspected rheumatic heart disease to assess mitral stenosis and other rheumatic valvular heart disease. We found it very useful, really, as a preliminary screening for the patient, and then that divide the patient into low risk, intermediate, or high risk, and then we call them to the center for a proper echocardiogram. I think it's a very, very good device on availability, and also very easy to train. I mean, even you can train nurses and even junior echocardiographers to do it. Our experience with it actually is very good, but it's very expensive. It costs about $4,000 in Sudan, and this is not widely available. In the pediatrics, actually, our colleagues are using it widely, especially in the rural area. But now we have stopped using it because nowadays we've got an availability of cardiogram in the heart center, and we've got a number of dedicated heart center who is available machine.
So they actually did a study in Sudan where they used portable ultrasound echoes, and they compared 3 views with 10 views with a full study, and they looked to see the detection of rheumatic valve disease using that approach. All patients then went on to have a full diagnostic echo, transthoracic echo, and they found that actually the difference between limited 3 views and a full study was in the detection of screening for rheumatic valve disease. It was very good, very similar. So do you see a distinction between use of point of care ultrasound in screening versus the diagnostic element?
I mean, it's a very good tool for screening, especially in pediatrics. I mean, the window is better, and the patient, just wall is thinner, so we can get a better view even we use. But maybe in adult patients with the difficult windows, I don't think there's a lot of difference between the two. So I think that, I mean, in our hands, I mean, in the adult patients, it's as good as the machine for the screening.
Thank you. And I was going to ask the same question to Dr. Andrews. In your experience, do you see that distinction between the use of ultrasound as a screening tool versus a diagnostic tool?
I think that it all depends about the context that you're using the ultrasound. I think that as we get more experience in acute medicine and as we get more experience in general medicine, to use it as a form of triage has a role, but I would like to be training more people to be able to use it sequentially and daily as part of their assessment of the patient. Harking back to what I was saying with Professor Gineggio, that I think can be one of the most valuable rules is repeated assessments and then having targeted outcomes. As a basic screening tool, I find it incredibly useful whenever I do procedures. And so, for example, an acidic drain now, I won't do unless I've actually put a probe on the patient, because I think it's cheap, easy, we've got ready access, and it means that I can reduce my complication rate to pretty much zero. So I think in some situations, we're going to find that it's already the gold standard. It's going to move to be the gold standard for more procedures as time goes on.
Thank you.
Can I jump in, please, if you don't mind? Just a couple of comments. I think I agree with Dr. Badri as well. It depends on what you use the tool for, either as a screening tool or as a tool in difficult cases, or as a tool to reduce the complications of a procedure you're doing. So partly answering what Saeed was asking, most of the cardiology trainees are now required to be trained in ultrasound use for vascular access for different cases, particularly for things like femoral artery access, femoral venous access for TAVI cases, and so on and so forth. We all have anecdotal examples of absolutely horrendous complications from seemingly straightforward procedures in radial access, in femoral access, and you suddenly find patient has had a retroperitoneal bleed out, the sheath is taken out, and so on and so forth. So we've had examples of that, and that is what has driven the need for training trainees in being capable of doing this before you start poking needles into it. As an example of a screening tool, can I just also raise, so British Society of Echocardiography has an established outreach into Kenya and South Africa with teams that go out there to do focused ultrasounds for rheumatic valve disease in patients that have been screened by the local team. So they've trained nurses and physiologists locally to go outreach into the bush area and pick up people with suspected rheumatic disease, who's then have been selected to come in to get greater, sort of more focused on detailed ultrasound examinations. So you can use that ultrasound to actually direct your resources. So you're right. I mean, 3 images of the mitral valve from different angles is enough to tell you whether there is a high probability of getting a decent, is this going to be mitral stenosis or MR or not? There are, however, other features that follow on from the initial screening for which you need the more detailed analysis scan as well. So one is not mutually exclusive of the other. It's how you utilize the resource in your hand that gets you the biggest bang for your buck.
Thank you. And thank you for that. I just wanted to add very, very briefly that I was very enthusiastic with echocardiography, and I spoke to some of the senior echocardiographers, the chief echocardiographers in one of my centres, for using echoes as a screening tool to then go ahead and do a full departmental echo. And they were sort of a bit resistant to that, in the sense that they felt, well, actually, if you're doing an echo as a screening, you should be able to perhaps prevent them needing a further transthoracic echo, particularly if it's normal. So I don't know if you have any views about that, whether what your feelings are about that.
We've gone through this phase of our physiologists looking at things like focused echoes. So we used focused echoes in patients where we've got an established diagnosis and we need to understand whether there is deterioration or change in any shape or form. So for example, somebody who is known to have aortic stenosis and comes in with breathlessness or chest pain, you need to understand whether the ventricle is normal or not, and whether the valve is deteriorated or not. It takes about 10 minutes to get that out of the way. And that is very different from getting a scan for somebody who's clinically unwell and has a murmur, and then you need to do a full detailed study. So it depends on how you develop your pathways and processes in utilizing the expertise that you've got. Our physiologists also have exactly the same same opinion, i.e. if you can do a focused echo, then you should be able to do a detailed echo, because if you pick up something, then you need to be able to go and verify what you've picked up. That is true as a statement in principle, but that doesn't necessarily mean that everyone who scans should be able to scan in detail to the extent that you can completely and thoroughly assess all aspects of all so dysfunctions that you might, or anatomical variations that you might find. And the example I've always put forward is that there are people who do pediatric echocardiography or adult congenital echocardiography whose experience is very different. And even within the spectrum of physiologists, there are people who focus and have greater experience in doing that in more detail than they would do for any other part of the echocardiographic presentations. So it is advantageous to know a lot, but it is not disadvantageous to know what you want to know to start the process and then direct it to somebody who can do it. It's just how you use your resource.
And I think you're right. And the risk for me is in having a normal, scan. Is it really normal? That's for me is one thing I've always been very careful about. Is there anything else that anyone else would like to comment on? Dr. Saeed?
Just a general comment. Ultrasonography was in the hands of radiology, and now it's moving into the hands of acute physicians, general physicians, cardiologists, nephrologists. So it's migrating out of their field. And the usual pushback is, it's our work, not your work. But then if you do it, we're not responsible for you. And you have to have your own governance and structures in place. And that in the early years, you always get that. And then suddenly, when you then explain to them, well, that's fine if you want you to keep on doing the work, then you can have it all back again. But then you have to provide timely, efficient resource for a daily scan, like we may want, on purpose for review. And then they go, no, we can't do all that work. So it's a negotiation to be had with those. You need to bring them along. This is what we've tried to do. If you don't bring them along, they will put a resistance up, because people will challenge your acumen and your skill level to do these kind of scans in all those areas. And you can imagine when something goes wrong, somebody will jump down the neck and say they're not trained, they haven't got our blessing, they haven't done this, they haven't done that right. So we need to bring everybody along, especially when it's not in our field. It's not our field really, it's in the radiology field. So it is, as I've learned from Professor Shahid Janejo, that you always bring everybody along, because you just need them at some point in the future when some things go wrong. So that's a general term. See, my tutor is great.
It's great to see that you picked up the unspoken word well, Saeed. Thank you very much.
It took a long time though.
I think you also highlight the debate, isn't it? So you are fantastically good at doing what you do in renal medicine. But then if I start screening my patients and managing renal failure in those patients, you cannot be held accountable from a governance point of view for the outcomes. And therefore, it is my duty to take you with me and so on and so forth. So I think that we're talking the same principle. So no, fantastic. Well done.